breast cancer. So with this, if you see the data of India, so out of 14 million new cases every year, and out of which there are around 9 million deaths is happening per year. So lung cancer, according to this data, remains the 4th position in India. But unlike India, the mortality also, if you say in males, is a second most common cause, and if you say if you combine both sexes, male and female, then lung cancer is the fourth most common cause of death due to cancer. Interestingly, if you see in Nepal, because Nepal is like a border of India, is like a state of India only, but if you see the pattern of cases, we have around 22,000 cases per year, out of which 14,000 cases are dying due to cancer. And if you see overall incidence, lung cancer is the #1 cause in Nepal, if you say in males, and if you combine male and female, and death is also due to lung cancer is the #1 cause. So unlike India, we have a lung cancer, cancer death is due to lung cancer at #1 position. So I'll skip this one. All of us know that most of the lung cancers are non-small cell and the rest is small cell and other cancers. So coming to natural history of lung cancers, is starting from DNA damage to cells up to most of the cancers are diagnosing at very low advanced stages. Around approximately 80% of total lung cancers are diagnosing in very locally advanced or metastatic diseases, where 5-year survival remains very poor, less than 20%, as low as sometimes up to 0 to 4%. So with this, the risk factor of lung cancer, if you say, is smoking is the #1 cause, as it contains more than 450 carcinogens and is directly proportional to the number of lung cancers. So there's a lag period, and that's where concept of lung screening came, where you have a lag time, where smoking years counts, and it is directly related to the number of cancer cases. Other risk factors beyond smoking, like environmental factors like radon, air pollutions, or family history, or other factors, or combination of multifactorial can be a cause of lung cancer. So why prevention and screening? So if you say approximately 85 to 90% of total cancers are caused by voluntary or involuntary secondhand cigarette smoking, and it is due to, and that smoking is associated with second primary cancer treatment, and it can lead to complication in the during treatment time. It can lead to a poor survival and poor quality of life. So the concept of low dose CT has come for the lung cancer screening. And if you see the lung cancer risk, most of the cancers are happening in who smoke, around 90%. So we used to smoke, around 50% constitute of that, and then less than 40% who are currently smoking, and 10 to 50% of total lung cancers are occurs happening in never smokers. So what is screening? Of a test done to detect a cancer before symptoms to develop, and typically do not appear until the disease is advanced. So symptoms of lung cancer is appear very late stage. So we have to find out the disease at early stage. Till now, there has not been any effective test. Lung cancer screening has not been implemented. Unlike chest X-ray, so no benefit. But after this trial, NLST trial, where they have enrolled 50,000 of total populations, and between 54 to 74 years age groups, and included current or former smokers, and then randomized into low dose CT and chest X-ray, and they found that there are significantly decrease in lung cancer mortality due to lung cancer if you apply low dose CT, and thus establish the role of low dose CT in lung cancer screening. Similarly, these 3 trials, NLST, Nelson, and MILD, these are the 3 trials, positive randomized trials, which have shown the decrease in mortality by applying low dose CT, chest CT, in case of lung cancer in high risk populations. So they have found that, by applying low dose CT, the mortality is decreasing by from 20% to as far as 39%. So further, the evidence was supported by Cochrane meta-analysis, and they also found the same result, and lung cancer mortality definitely decreased by applying a low dose CT screening in case of high risk population. And what are that groups I will be talking in the later slides. So this is again one of the most powerful paper in New England Journal of Medicine, and they have clearly said with the Nelson trials, the efficacy of low dose CT screening of lung cancer is confirmed. Our job is no longer to assess whether low dose CT screening for lung cancer works. It works. Our job is to identify the target population in which it will be acceptable and cost effective. So if you say low dose CT scanning can diagnose your lung cancer at a very early stage where your survival is as high as more than 90%. So if you see the risk categorization, who should get a screen? So NCCN clearly recommends LDCT or helical low dose CT scan for high risk population. So what are the high risk populations? So age more than 50 years with at least 30 or more PAC years of history. If someone has smoked or if they have quitted, then within 15 years of quitting the smoking, so they should be screened with the low dose CT. And there is one group low risk where age less than 50 years with or without smoking history less than 20 PAC years. Screening are generally not recommended. So previously it was like 55 to 80 years, but now they have decreased age, so they have now put 50 to 80 years. But NCCN does not currently believe that exposure to secondhand smoke is an independent risk factor because that data is very weak. So what are the benefits? So if you can you do a screening, you can detect lung cancer at a very early stage where cure is possible, and it can also decrease your mortality. If you say in US there are 7 million Americans are estimated to be eligible. So in country like US also only less than 4% populations are undergoing the screening. So think about our population and our problem. So we have a lot problem and we are not able to implement that screening part. So what are the risks? So false positive can be risk because finding a nodule spot that is not a cancer, and most nodules, at least 90% seen on CT are not cancer, like in our region of the world where granulomatosis lesions are very common. So may require additional testing. And then similarly false negative case, like negative screening, that does not mean that you don't have a lung cancer or can get a lung cancer. So these are the risks. Other risk factors are like radiation exposure. You can have a radiation exposure similarly to 12 chest X-ray if you do one low dose CT. Cost can be a major issue in particularly in like country like our Nepal, India, and I think no insurance companies are covering for lung cancer screening. So that is also one problem. There may be additional cost of CT scans if you find something on chest, low dose CT, or if your high risk groups meets all the criteria, then you have to go for CT. Then cost definitely will be issue. And after testing, definitely then further testing will be another issue in a region like us. So what do the results mean? That you can have either negative screen or positive. If you have a negative, then no nodules seen on your CT images. If you have a positive, then nodule was seen on your CT images, and about 50% of total patients will have at least one nodule. So most of these are not a cancer. So positive is
you have only 1 minute, Dr. Virendra.
Sure. So there are three categories of opacity seen on the CT image, like Glasgow, solid, non-solid, and solid. So if you have a solid less than 6 millimeter, annual low dose CT scan will be preferred. If 6 to 8, low dose in 6 months, and then accordingly. If more than 8, less than 15 millimeter is there, then low dose CT in 3 months, depends on your characteristic of your nodules. Or you can have a testing or your FDG PET CT or further testing. For non-solid nodule, if you have a less than 20 millimeter, annual screening is recommended. If you have more than 20 millimeter, then low-dose CT in 6 months. So there are various risk models, and most of them are the most commonly used as Tamamegi modules, which includes 11 factors into consideration to calculate the cancer risk in a particular individual. Future direction, there are various models which included this one, just 1 minute. And further artificial tools currently are under development. It might come in the future. So this is the calculator. You can calculate your risk according to these factors. So these are the countries which have already implemented lung low-dose CT screening. But among Asia, I think Abu Dhabi, they have started recently along low-dose CT scanning. So prevention, stay away from tobacco, avoid radon exposure, or avoid or limit exposure to cancer-causing agents. So definitely lung cancer screening with low-dose CT decreases death from lung cancer. Screening is not appropriate for everyone, only shown to be a benefit for those at high risk of lung cancer, and lung cancer screening should be done in structured programs experiencing lung cancer. So screening is not a substitute for quitting smoking. So yes, unfortunately, the main question still remains: is it time for lung cancer screening? Definitely yes, and it's very urgent. Thank you so much.